Good afternoon. My name is Whitney Witt, and I am the inaugural Dean and Professor at the College of Health at Lehigh University. I want to welcome you to the first webinar in our series entitled Population Health Weekly. The webinar will focus on COVID-19, and in today's session will provide the College of Health faculty perspectives on the pandemic and answer questions from viewers. I want to especially welcome Lehigh students, particularly our early decision students and our prospective students. I also want to welcome staff, faculty, alumni, and trustees to what I know will be a great discussion today. I'm very pleased to have our inaugural faculty for the College of Health here with me today. I will go through the participants. I will serve as the moderator for the webinar, and I've already introduced myself. Dr. Hal Skinner is the Associate Dean for Research and an Associate Professor in the College of Health. He's an epidemiologist by training, and his work ranges from understanding the genetic and molecular influences on disease risk through developing methods for measuring healthcare quality. Next, we'll hear from Hyunhyuk Choi. She's an associate professor in the College of Health, and she is trained as an environmental epidemiologist. Her research focuses on early life exposures to complex air pollution mixture and their developmental consequences throughout childhood, including asthma and obesity. Next slide to Fatima Wakil, please. Next slide. Next slide. And one more. Okay. Next slide. Okay. So then we'll hear from Dr. Fatima Wakil. She is an associate professor in the College of Health. Her research interests lie in maternal and child health and women's mental health, specifically the balance of maternal stress and resources over the life course and its relationship with perinatal and child health outcomes. And then finally, we'll hear from Dr. Ed Gomez. He's an associate professor in the College of Health. He's a political scientist by training, and his work focuses on global health policy and politics with a focus on emerging middle income countries. In addition to his previous academic appointments, he's also worked as at the World Bank, the Rand Corporation, and he's also a veteran of the US Air Force. Next slide, please. So I want to first take a moment and frame the discussion today. The 2019 novel coronavirus, or what is now known as COVID-19, is a new virus that causes respiratory illness in people and can spread from person to person. It is now a global pandemic, and the United States is now the epicenter. Tracking epidemics and pandemics like COVID-19 really underscores the importance of population health. Social, economic, and environmental factors have increasingly been tied to the impact of emerging diseases on health outcomes. And population health is really an important approach that takes these factors into account when thinking about prevention all the way up through policy level interventions. Today, we'll give you a brief overview of how COVID-19 intersects with different aspects of population health, and then we'll have time for questions and answers. So I want to first focus on this idea of flattening the curve. I'm sure everyone on the call has probably seen some variation of this figure, and I want to just talk briefly about what it means. And really what we're talking about when we say flattening the curve is we really are talking about changing the slope of the epidemic curve. In other words, we're trying to slow down the spread of disease. And the level of steepness of the epidemic curve is usually an indication of how quickly the disease is spreading. So flattening the curve can have a significant impact on health outcomes And by reducing the rate of the spread of COVID-19, we can reduce the risk to vulnerable populations, the impact on the healthcare system, and serious complications in mortality. So early and widespread testing for COVID-19 is critical for flattening this curve, and also physical distancing. Next slide, please. So in this slide, I wanted to show you the growth of new cases. And what you can see here is that the growth in the number of new cases in the days since the 100th case by each country. And what you can see here demonstrates where the US is in comparison to other countries. We're sort of that top red line in the graph. So I am now very pleased to turn it over to Dr. Hal Skinner, who is going to give us a more in-depth overview of COVID-19. Dr. Skinner?
Hi, thank you, Dean Witt. It's a real pleasure to be here today. And I'm just going to go through some of the sort of high-level features of where we are in the COVID-19 pandemic and what we've been thinking about. I would like to say that if you do have questions or want more detail, please feel free to ask them using the Q&A feature at the bottom of the screen. I'd be happy to get into that at the end of the presentation section. Could I have the next slide, please? So what Dean Witt showed you was an overview of the trajectory of COVID-19. This presents a more comprehensive view of the status of the pandemic, looking not only at the number of confirmed cases on the left-hand side, which shows the US is out in front in terms of the number of cases, but also looking at the number of deaths, and then the proportion of cases who have died, or the so-called case fatality rate. Again, you can see there's quite a bit of variability across nations, even among those that are at the forefront of the pandemic now. The third column shows the cases per million people. So this is a way of standardizing the size of the outbreak across populations, where different countries have different sizes of population. And so in that case, Spain has the highest number of cases per million people, Switzerland next, Italia following that. And again, finally, in the rightmost column, the deaths per million people. So again, standardizing across population sizes. Could I have the next slides, please? So looking back at the earliest wave of the epidemic in China, it was noted that the majority of infections that were detected were mild. 81% were mild. That left 14% being severe hospitalized and 4.7% that required ICU beds. These numbers have been fairly consistent across other countries. We're still waiting for concrete information about how this is playing out in the United States, so we could see with more detail what to expect in terms of healthcare resource utilization. Could I have the next slide, please? Another feature of COVID-19 that was identified early was that the mortality seemed to be much more heavily weighted towards older age groups. That is, we don't think necessarily that they're more likely to contract the virus by transmission, but the consequences are much more severe for the older cases. Again, this is data from Italy and China. We are keeping an eye out for what this looks like more specifically in the United States. I would also mention CDC came out with a report recently indicating that as many as 25% of people who are infected with COVID-19 have zero symptoms. And that presents a challenge for infection control, even with testing in place. Next slide, please. The mortality that's noted among older people also extends to higher mortality among people who have pre-existing conditions, cardiovascular disease, diabetes, respiratory illnesses, high blood pressure, other cancers. Whereas the mortality among people with no pre-existing condition is 0.9%. It's also worth pointing out that these are very common conditions, especially as people get older. We all know someone who's got at least one of these And it's important to keep in mind that this doesn't exclude the need to prevent transmission of infection to protect people who have these very common comorbidities. Next slide, please. And then the number of people who, so this just goes to show that the mortality is very low among people with no conditions. One condition, two condition, three condition mortality increases dramatically with the addition of more conditions. Next slide, please. So how does COVID-19 compare to other communicable diseases? This was a topic of widespread discussion sort of early on in the pandemic when we were thinking about how do you calibrate response to something that's emerging. So we can see here the orange rectangle represents limits of our confidence in how transmissible COVID-19 is. Looking along the horizontal or x-axis there, that's the average number of people that is infected by each sick person, otherwise known as R0, or the basic reproductive rate. You've probably heard quite a bit about that in the news lately. And then on the vertical or y-axis, we're looking at the percentage of people who are infected, who are identified as cases, who die. And so you can see that the orange rectangle for COVID-19 contains the so-called Spanish flu or the 1918-1919 pandemic influenza. The models that you may hear about where people are talking about the potential for 2.2 million people in the United States of dying from COVID-19 infection, those come from these parameters from models like this and are applied to cases where the disease transmission is allowed to proceed without any intervention. Could I have the next slide, please? And another key feature that we're interested in with COVID-19 is what's the incubation period? That's like how long does it take the disease to manifest itself in an individual once they're infected? And there's a wide range of uncertainty around this, but it's been observed that anywhere from 2 days to 7 days is a very typical time, but in some cases up to 12, 14 or more days between the presumed infection time and the manifestation of symptoms. Now, one of the reasons for this uncertainty could be because there's so much asymptomatic transmission of the disease happening in the population. So what we presume to be the event of infection, the contact with someone that is known to be infected, might not have been the actual event of infection. It could have been someone asymptomatic later on. So it really underscores the importance of trying to get at these accurate pieces of information so we can better model and understand what is happening with the disease, but also how we might intervene to prevent the transmission of disease in the population. Next slide, please. And finally, it's not just the transmission of disease by virus from person to person that we're interested in, but we're also interested in the transmission of information about the virus. So you can see the relative mentions of COVID-19 in the media here versus other communicable diseases in recent times. And my colleagues will pick up more on these other themes about how COVID-19 infection intersects with the rest of our understanding of population health, but also society. Next slide, please. Okay, so I'm going to hand it off now to my colleague Hyunuk Choi, and I'm going to hand it back to Whitney, and who will introduce Hyunuk for you. Thank you very much.
Oh, it's great. Dr. Choi, please, without further ado, please take it away.
Well, I like to first of all thank Dean Witt and Ms. Sherry Buzz, Ms. Jeannie Cassis, and the team at the LTS for organizing this very exciting opportunity to have a dialogue with you all. So what I like to do in the next set of slides is to try to break down this current epidemic of COVID-19 in terms of discrete risk factors that we do understand as a foundational, stepping stone to develop, not only to understand quality, but also to develop strategies to keep us healthy. So I am going to focus on three main players in this epidemic. That is the infective agent, the SARS-CoV-2, the virus on top, the human host shown in the lower right, and the environment in which that we live. Next slide, please. So I'm going to start our talk with the global distribution of particulate matter 2.5. So these are pollutants of tremendous concern because they have an ability to get into the lowest parts of our lung, into the smallest sacs of our lung system, and directly pose harm by interacting with not only with multiple cells in our body, but also react with the cytokine. And in the case of COVID-19, I mean, induce very dysregulated immune response in humans. So, but before I get to that, I mean, there are three messages that I like to convey through this map. That is, you're seeing the distribution of PM, particulate matter 2.5 over the world, in which the orange, the yellow, orange, and the red represent the concentrations that are far beyond and above the global limits set by WHO as the safe limit. And incidentally, about 300 million children worldwide live within these areas. And why do I mention this? We know that air pollution exposure in the womb, you know, from the moment of conception to the day that you're born, to as you grow, you know, throughout your toddlerhood and in your childhood into adolescence, has a profound life-altering effect in shaping your immune system. So much so that, you know, if your immune system is shaped by outdoor air pollution, you're much more likely to get infected with opportunistic infection, such as COVID-19 virus. Once you do catch such an infective agent, your responses to such infection could be much more severe if your immune system is compromised. And what we do know from other viral infection early in life, such as rhinovirus infection in very young children, is that they pose a very long, lifelong consequences, such as asthma. That is, they permanently alter the developing respiratory and immune system so that your response, your ability to interact with the environment permanently changes, thereby increasing your risk of catching developing COPD or asthma during childhood, adolescence, and or adulthood. So next slide, please. So hypothetically, if I were standing on a street corner in Allentown where I live, and I caught the whiff of a diesel truck that was passing by, and it happened to have a huge amounts of particulate matter 2.5, as you see in that brown sphere, as you see, you could see that the inert core, the black inert core, is encased by much more chemically reactive layers on top. The yellow, the gray, and the brown layers are what's conferring these toxic properties to these particulate matters that we inhale. And not only that, I mean, it's perfectly conceivable and very plausible that virus could be carried by these particulate matter and end up in the deepest sacs of our respiratory system, such as alveoli, and get transported into our bloodstream through diffusion, as we absorb oxygen and emit carbon dioxide. I mean, they are perfectly capable of getting into our system through this way. And in the process, one way they might do this is by overwhelming the macrophages from performing their regular duties, overwhelming them, so to speak, and then initiating this extremely storm of cytokines, this overproduction of these very arrows and arrows, if you will, against these toxic agents. We don't yet understand why our bodies do this, and this is one of the things that needs to be clarified. But one thing we do understand at the moment is that apparent mechanism of that the COVID-19 virus overwhelms the body is that it initiates a extremely disorganized and dysregulated immune response in the human host. Next slide, please. So just to compare quickly the size of some of the agents that we've been discussing, what you see on the left is human hair, which is perfectly visible in our naked eye, compared to PM10, shown as a blue sphere cartoon. It doesn't look like that in real life, but I mean, for the sake of it's shown as a blue just for the comparison of the size. Compare that to PM 2.5, which gets into the deepest parts of our lung, shown in yellow sphere. And compare that to the red dot, which is even less, much less visible, which typically represents the size of a typical virus. Next slide, please. So this brings me back to what both Dr. Witt and Dr. Skinner had alluded to earlier in their slides. That is, once the virus gets into our system through most typically inhalation process. I mean, we don't know yet whether inhalation is the only route of exposure, but we speculate that this may be a very important route. We do not yet know why some people develop very mild symptoms while the others develop very severe responses, including pneumonia, including acute respiratory distress, inability to breathe. So all of these are yet to be clarified. But what I could tell you is that there are things you can do at this point based on what we do know to protect your immune system, protect your health in a tip-top shape as much as possible. And that is, if you live in an area with high levels of ambient air pollution, it's probably not very wise to keep your windows open. It's probably also a good idea to keep the indoor air as mold-free and as clean as possible. If you like to fry all your food, it could also generate a fair amount of particulate matter. So I'm going to stop there and turn the mic over to our Dean Witt and on to the next speaker. Thank you.
Thank you so much. It was really great to get that overview and how COVID-19 is affecting particularly people who may be at risk for acute respiratory distress. So thank you, Dr. Chow, for that. And so I want to move on now to Dr. Fatima Wakil, who's going to talk to us specifically about how COVID-19 is affecting women, children, and families.
Hi everyone. Thank you so much, Dean Witt, and to all of our viewers today for joining us. So many of us, if you look at the cartoon on the left on my slide, many of us can relate to this cartoon, I'm sure. It really shows a best case scenario of a family practicing social distancing measures amid the COVID-19 pandemic. A mother is working on her computer in the laundry room while her kids are all sort of descending upon her with demands and complaints. So due to COVID-19, many parents now find themselves juggling full-time jobs from home, household responsibilities, and having to manage their kids' needs during the day, including homeschooling them. So as I mentioned, this is really a best case scenario and doesn't apply to many of the vulnerable women, children, and families around the US and around the world. So let me just point out a few things in this picture that actually show privilege. So the picture illustrates a two-parent household, and it appears that both parents have jobs that allow them to work from home. Unlike hourly workers who've just lost their job during the outbreak, or the many essential workers who have to report to work and face the very real risk of getting infected, or the many people who can't go to work due to a lack of childcare. The family also appears to have a stable home. So many of our most vulnerable populations don't have homes or stable housing, which is likely exacerbated with social distancing measures. The kids are also able to ask for snacks. Many children and families experience food insecurity, and this problem is now heightened. My kids are unable to access free and reduced lunch at school. And then one of the kids is able to confide in his mom about his anxiety regarding the COVID-19 situation. Not all children have the stable adult in their life who they can confide in when they're not in school or have regular access to necessary services. So there are a wide range of maternal and child health issues to consider during the COVID-19 pandemic, and I'm just going to be touching on a few of them. So to start with the transmission of the virus. We know that pregnant women, due to changes in their bodies and their immune systems during pregnancy, can be badly affected by some respiratory infections. It is therefore important that they take precautions to protect themselves against COVID-19 and report possible symptoms to their healthcare provider. We still don't know if pregnant women with COVID-19 can pass on the virus to her fetus or the baby during pregnancy or delivery. To date, the virus has not been found in samples of amniotic fluid or breast milk. However, there is very limited research that has been done on the transmission of the virus from mothers to kids during pregnancy and childbirth. And the limited evidence suggests that if the mother has active respiratory symptoms, this can be transmitted to a newborn. And the next thing I'd like to talk about is routine healthcare. So one concern that we have is that pregnant women usually attend about 14 prenatal visits. That's visits to the doctor during pregnancy. This may be reduced by approximately half, with telemedicine playing a larger role. So telemedicine is already endorsed by the American College of Obstetricians and Gynecologists for patients in rural settings. However, this is becoming much more normative in all settings with the COVID-19 pandemic. Pregnant women are also able to do some at-home monitoring, such as for high blood pressure, diabetes, and contractions. And telemedicine can even be used to speak with pregnancy consultants, such as genetic counselors and endocrinologists. Another concern we have are well baby checkups, which are typically done 3 to 5 days after birth, and then every few weeks and every few months in the infant's first year. Thankfully, these are still prioritized for the time being as for face-to-face visits in healthcare settings. Another important factor I'd really like to focus on is trauma and stress. So we know that high stress home environments will increase the likelihood of domestic violence and abuse that children either experience or observe. As schools are not physically open, children are unable to obtain much needed access to the stable and safe environment, and the adults who would normally serve as key emotional support providers. In terms of pregnant and preconception women, a lot of research has been done that show that stress before and during pregnancy has been associated with adverse pregnancy and birth outcomes, such as low birth weight and preterm birth. So one important way that we measure stress is through the use of stressful life events. And the COVID-19 pandemic can certainly qualify as a stressful life event. So especially for those women who are in vulnerable populations who already experience a high level of stress in their lives. Along those lines, we can also think about mental health services. So mental health is increasingly becoming a critical health issue among children and adolescents. With the social distancing measures in place, these important services may not be occurring face-to-face or are likely reduced. And those who do not have access to stable internet services or a stable home environment may not be even able to access telemedicine for mental health at all. The same goes for women who may have just given birth and are experiencing postpartum depression. Next, I'd like to touch on food insecurity, which I already talked about a little bit when discussing the cartoon. So children who are food insecure typically access free or reduced breakfast and lunch at school, which they are now unable to access with schools closed. However, I am very encouraged to see that many communities across the country are coming together to ensure that food is delivered to or is available for pickup for families in need. And then finally, I'd just like to touch base on children with special health care needs. So children with special health care needs typically require additional supports within the school, for example, an individualized education plan or an IEP, and in home, so things like ABA or applied behavioral analysis for children who are on the autism spectrum disorder, on the spectrum. So with social distancing measures in place, these services are not available in person, and they may not be as effective virtually. Another concern is the provision of accessible learning activities for children who need it. And then finally, children with special health care needs, especially those with learning and intellectual disabilities, typically require and really thrive with routine, which is now much more difficult for caregivers and parents to provide in the midst of their own work and home responsibilities. So these are just some of the short-term impacts of COVID-19, the COVID-19 pandemic on maternal and child health. But it's really important to note that all of these challenges will have very long-lasting effects on the health of women, children, and families in the US and around the globe. So now I'd like to turn it over back to Dean Witt so she can introduce our next speaker. Thank you.
Thank you, Dr. Wakil. That was very, very insightful and very helpful in thinking about how this pandemic is particularly affecting women and children and families, both here in the US and around the globe. I'd like to now turn the podium over to Dr. Ed Gomez, who will be talking about the policy implications both here in the US and around the world. Dr. Gomez.
Yes, thank you, Dean Witt. Thank you, everyone, for coming out to our session today. It's certainly an honor to join all of you virtually and to talk about this epidemic from a political science perspective. As a political scientist, I've been very intrigued and concerned about how the US political system and elections is interfering with the government's policy response to COVID-19. And in this presentation, I'll discuss three big concerns that I have as a political scientist and policy expert, followed by some policy solutions that I think the government could possibly follow. I have three general concerns. The first is political interference and delay in policymaking and implementation processes, building adequate health systems capacity, and political marginalization and treatment towards others in society, such as illegal immigrants and the poor. And some policy levers and solutions that we could pursue is one, working more closely with the states and the private sector to expanding testing, applying the Defense Production Act across all health sectors, and engaging in global health diplomacy, that is the Trump administration working with other governments to find policy solutions. Let me turn now to political interference. This has probably been the most politicized epidemic since the HIV/AIDS epidemic emerged several decades ago in terms of politicians talking about the disease in the media. I'm sure you've seen on CNN and NBC a lot of politicians constantly talking about the virus, and it's sort of taken over the discussion. This virus probably emerged at the worst time ever, in the middle of a heated presidential election. And because of this, there was considerable policy delay due to the election. Our analysts argued that the Trump administration initially downplayed the seriousness of the virus, referring to it as a common flu, and at one time in a campaign rally, referring to it as a hoax introduced by the Democratic Party, sort of undermine the government's position. Trump claimed also that the virus was very much under control. The Democrats and scientists, on the other hand, argued that the policies at the time to containment was not working, and there needed to be more accelerated response on social distancing in order to flatten the curve, as Dean mentioned earlier, to reduce the number of acute cases that are emerging through social distancing and other measures. Major policies, however, were delayed due to bipartisan conflict. For example, the Families First Coronavirus Response Act, which was implemented on March 18th, was delayed by nearly a week due to debates within the House of Representatives. Democrats pushed for greater work compensation and introducing other benefits, such as expanding SNAP benefits, which is money to buy food for poor families, especially as children are staying home now. As Fatima and Dr. Wakil mentioned earlier, parents need more money to buy food for their children. Trump and Republicans complained that the Democrats were sneaking in too many entitlements, and they were, in a sense, creating a huge bureaucracy. Others agreed, however, argued that there was a lot of extensive delay because of haggling between Speaker Pelosi and the Trump administration over the final details. Altogether, it was finally passed, but it took nearly a week to get implemented. It was a great example of how bipartisan conflict and conflicting views can delay policy implementation. The next challenge has been federalism. Trump initially told the states, for example, that it was their responsibility to respond to the epidemic by increasing their resources, infrastructure, beds, masks. He blamed some of the governors, such as New York Governor Cuomo, for not preparing early enough, and this was mentioned in some of the media. This could have been perceived, however, as the Trump administration's commitment to decentralization, allowing the states to have control over health policy matters, which is normally the case. Others could have seen this, however, as a political tactic to sort of, reduce responsibility on the president and, give the responsibilities and hold the states accountable rather than the president. The next problem that I've seen is health systems capacity. Still, months into this epidemic, there still has been a not as strong as a political commitment, a policy commitment by the central government in assisting the states in building up their infrastructure, and especially protective gear for hospitals such as masks. It's very hard to believe that is a wealthy industrialized nation that we're having a difficult time ensuring that all hospitals have the proper masks that they need. And so there's really been a lot of discussion in the media about how the central government could be helping the states more in providing these masks. There's been also ongoing needs in troubled cities, or what we refer to as hot spots, such as New York City and Chicago and Louisiana, for example, and New Orleans, major cities that are in dire need suddenly of these materials. And there simply hasn't been an insufficient number of beds and ventilators as hospitals. Recently, the governor of Illinois has been on TV talking about how very much needs more ventilators and beds, and complaining that the government hasn't been giving enough resources. But another major challenge has been the politics of marginalization. Since the Trump administration, at the beginning of the Trump administration, he has been consistently committed to tackling the illegal immigration issue. In the process, however, this has added to social marginalization of immigrants with several consequences. Illegal immigrants, for example, in this context, may be afraid of reaching out to their local hospitals to talk about their particular health conditions. If they have symptoms of some kind, they believe they may be infected with the virus. Due to their illegal status, they may be afraid of going to the hospitals to meet with people, with experts. The virus may also continue to spread in isolated communities where the immigrants are. And that could lead to a spread within their community and possibly contribute to another rise of a wave in the future of reintroducing the disease to the general public. And another issue that needs to be addressed is how is the government going to reach out to immigrant families? Since most families have now left ICE detention centers and are staying with sponsored homes, how will local health providers reach out to these families and provide care? What is treatment going to be looking like for these recent immigrants that are crossing the border and being held at ICE detention centers? And how will that treatment be monitored and ensure that they're getting the proper care? These are things that really needs to be discussed and where the government needs to focus on to ensure that, that this population is being adequately addressed. And finally, the issue of homelessness is a major issue that needs to be addressed. How is the government, central government and state governments working to meet the needs of the homeless population and keeping them safe during this time. Some cities have introduced initiatives where they have social distancing of people sleeping in parking lots. This is certainly going to be a need for the federal and state governments to coordinate to ensure there are more services like this being provided. But there are some policy solutions that could help all of us in the government during this time. The first is that the federal government could work more quickly and effectively with states in establishing testing centers. For example, the drive-through testing centers. There has been an agreement by the Trump administration to work with selected commercial enterprises such as Walgreens, Rite Aid, and Walmart providing drive-through test centers. But there still is a need to expand and provide this. The recent news that I've seen suggests there's only 5 such centers available now, despite these companies having all these different franchises and hundreds of stores. And so there's going to be need for, and can certainly lead to more cooperation in providing these test centers. Second, one good solution would be for the president to invoke the National Defense Production Act across all health sectors. The president has certainly done this with working with GM and providing ventilators and increasing the number of ventilators. But this could be expanded also to providing masks or providing protective gear for hospital healthcare workers. And finally, global health diplomacy. And this is when the government works with other countries to learn about policy innovations and experiences. And here, the Trump administration could work closely with other countries to learn about what they're doing, to learn lessons, and to possibly exchange technical assistance through the sharing of ideas on how best to intervene in these critical areas and needs. In conclusion, the good news is that it seems that the dilemma of bipartisan conflict is decreasing. Recent news has shown that Republicans and Democrats are agreeing that there needs to be done, something done urgently. The recent stimulus packages introduced as evidence of that. And also the Trump administration is certainly listening more to the scientists, and the fact that the social distancing recommendations have been expanded to April 30th certainly gives, based on recommendations from scientists, the new data, the fact that science is now, sort of shaping the policy, and that's an excellent, outcome that we're seeing. So we've learned a lot in terms of politics, and we've learned a lot about us as a society. And I look through this horrible disease, and I look forward to talking about this with the rest of you. Thank you very much. And I'll pass it over to Dean Witt.
Thank you so much, Dr. Gomez. That was very helpful in thinking about how policy and politics come into play in this pandemic. So we have a lot of burning questions. The audience is very excited about this topic. So I want to first start out with a question about why is the time frame for an epidemic without protective measures so much shorter than the one with protective measures? Would not taking protective measures at all shorten the period we are dealing with the epidemic? And I'll call upon Hal to answer that question.
Thanks. So it's an excellent question. It's one that comes up quite a bit. And in the simple model, that's exactly what you would expect. Under the figure that Whitney showed earlier, you've got a very high peak of cases, a relatively short period of time under the non-intervention. And then with curve flattening, you get a lower peak of cases over a longer period of time. And what we're buying is time. Time is a very important factor. We're buying time to come up with testing. We're buying time to come up with vaccines. We're buying time, more importantly, to treat the most serious cases. Right now, what we're seeing is that in New York, the medical facilities are being stretched to the limit. And if nothing were done, they certainly would be pushed past their capacity. And that would open an era of some very, very difficult decisions and very difficult situations that I think as a society we would prefer to avoid.
And I think there's a lot to learn to Dr. Gomez's point in the United States working with other countries to better understand how they've flattened the curve and what's worked and hasn't worked. So there's much to be learned around that. Thank you for that great question. So our next question, and I would encourage everyone to keep the questions coming. So please use the chat box to keep the questions coming, and we'll take as many as we can today. So the next question is about how many people we think could have COVID-19 and be asymptomatic. And I believe, Dr. Skinner, you had alluded to this. And I think it could be as many as like 25%, I believe is what you said, right?
Yeah, so if we're talking about the percentage of people who are infected, who are completely asymptomatic, the estimate right now is about 25%. But there's another thing that we need to think about is in the current approach to this, to be called a case, you have to be pretty sick and you have to seek treatment and get tested. So there are many, many more people out there who are not as sick, who are not being tested, who are not being confirmed as cases. So the total number of cases, including those asymptomatic ones, could be is going to be much, much higher than what we're seeing in terms of confirmed cases right now.
Great. So we have a specific question for Dr. Wakil. Is there any data or are there any data out there documenting a rise in domestic violence during this mandated period of social distancing?
Yes, thank you for the question. There is a lot of data globally. So for some examples, domestic violence cases in India have actually increased since the March 24th lockdown. And they're saying it's because a lot of the male partners are venting their frustration on their female partners who have no escape from their abusers. Another example is China's Hubei province, which was the initial epicenter of the outbreak. They found that basically since the lockdown, they found the domestic violence reports almost doubled. Mm-hmm. And they also found that, for example, in Spain, calls to the domestic hotline jumped about 18%. And the state-run hotline website actually saw a 270% increase. Mm-hmm. Domestically, we haven't collected as much data. There's been a slight uptick in domestic violence calls to the police domestically. However, as the time within shelter in place continues, it's going to force couples to remain home, and obviously, it forces the perpetrator of violence to have the power to control and abuse the partners and children and families, because there's no other place to go. So that's definitely, we do anticipate that there will definitely be a significant increase in domestic violence within the country as well.
And I would just like to add that in addition to violence, I think we can expect a rise in potentially neglect of children because children may be unattended because parents have to work or for a variety of reasons. So not just violence, but I think neglect is also a possibility as well, which puts them into danger in terms of their own health. Okay. Do we have any other questions from the group? Okay, if not, I'm going to move on to some questions that I have for the panel. I'd like to first ask each of you if you could touch upon the importance of testing and what it means overall, and also to the populations or the particular areas that you care about. So we'll start with you, Dr. Skinner.
Testing is very near and dear to my heart. So as an epidemiologist, I think the most important thing we can have is good, high quality information. And that would come in part through testing to know really the extent of infections. Right now it's being used mainly to confirm cases who have symptoms, and that information is not particularly useful in the treatment setting. If we want to start using testing in the prevention arena, we need to get out in front of the infection and do a lot more testing with the hope that the tests that we have will be sufficiently accurate and will capture the information about someone being infected in a phase when we can prevent further infection of other people.
Sorry, would any of the other panelists like to respond to the question around testing and how it affects particular populations or policy levers?
I would like to respond. Speaking of pregnant women and children, so pregnancy is already a very sensitive time for women. And right now we don't have enough data about the transmission of the virus from pregnant women to the children. And we really don't know how the virus shapes the intrauterine environment and the long-term impacts of having exposure to this virus in the womb, and the long-term exposure, the long-term impact for the child as they're born and they continue throughout their life course. That data is really important to collect if possible. And even thinking about preconception women, it's important to get them tested as well before they enter a pregnancy and take the virus with them into a pregnancy. So I would say that in everyone, of course, is a priority, but I would definitely say pregnant women and children are priorities for testing.
Yes, Dean Witt, I'd like to jump in on address this issue as well, if I may. I obviously agree with all my colleagues and everyone that testing is certainly critical in this time period. But I think that one thing that needs to we think more about are strategies for doing the testing. And I think more innovative ways, going beyond just drive-throughs. There's some other innovations could be working and establishing primary care teams to reach out to communities, poor rural communities, especially immigrant communities. And if we're going to learn from other countries, I think Brazil has done a great job they have these family health teams that are provided by the National Health, SUS, which is the National Health System Service. And these primary care teams go to communities. They're usually a team of doctors and nurses to provide treatment, and they go to the hardest parts of Brazil, in the poor rural, into favelas, in the poor urban areas, but also in the Amazons. And I think this is a time where the government can learn from Brazil and others on giving more tasks to the primary care workers, if possible, to reach these hard communities and even in urban areas. So I think that with regard to testing, that would be very critical. I have a colleague of mine who's doing a comparison, urban-rural comparison on testing, and is finding the rural areas are suffering a lot from that. So I think that I think that's something that we need to work on.
Great, thank you. Dr. Choi, I want to make sure you have an opportunity to respond.
Thank you, Dr. Witt. So I'm going to answer your question along with one of the very first questions that I've seen from the audience, which is that it appears that the SARS is comparable to COVID-19 both in R0 and death rate. Why does it seem COVID is far worse? So that relates to testing as well, but to what we know is that there is a very important difference between the behavior of SARS-CoV, which is commonly known as the SARS, the original SARS disease, and SARS-CoV-2, which is what we're experiencing right now. With the key difference being that the SARS-CoV-2 is extremely infectious among asymptomatic carriers, whereas SARS-CoV, the original one detected in China, was not infectious in asymptomatic people. Only when the people started manifesting symptoms, they were also were associated with shedding the virus. So in SARS-CoV, the original case, it was much easier to detect and to contain. And what we have here right now is essentially dealing with a disease that is being circulated without being detectable among asymptomatic people. So, in a nutshell, we cannot depend on the symptoms to detect the cases. Our case definition has to be based on biological markers within our system rather than how we feel, because how we feel is very variable and subjective.
Great, thank you. We did have a question about whether or not COVID-19 would be a research topic or case study for students in the fall, and the answer is yes. We definitely think that this is while a tragic occurrence across the world and really difficult situation, we do see this as an opportunity for all of us to learn as the pandemic unfolds, and hopefully things improve and we can learn from each other in terms of strategies and policy levers and how we can make a difference really at every level, from individuals, families, societies, and communities. So we have a couple of other questions. I think we have time for one more. Do you expect COVID-19 to go dormant over the summer, but have a resurgence in the fall? Is there anyone on the panel that wants to answer that? I'm also happy to jump in.
I'll jump in, and then you guys can jump in and correct me. Don't say something you like. So I think what we're expecting to see is this initial wave of infections will taper off and eventually become relatively small, and that will coincide roughly with summer. And we don't know to what extent summer climate will help attenuate the spread of infection for this. I think people were hopefully looking at the Southern Hemisphere to see that it might not catch on in the Southern Hemisphere, but it seems to be spreading pretty readily in the Southern Hemisphere. Dr. Fauci was on yesterday saying that, it's reasonable that we should expect another wave of this potentially in the fall. And that's what happened with the 1918-1919 influenza pandemic. There were 3 waves. The later waves were actually more dangerous because there was some antigenic shift that happened with that virus. And it's something that we have to be, I think, prepared for, and we have to be thinking about and making plans so that we're better prepared for subsequent waves than we were for this first wave.
Thank you, Dr. Skinner. Well, we have just a couple of minutes, and I would like to just wrap up. And I want to first thank Sherry Boos and Jeannie Cassis for their tremendous support in getting our first series up and running, our first webinar on this. And so we're really excited to join you next week. And I also want to thank Peggy Kane and Jason Spiegel from LTS, who were just really wonderful in all of their support in getting this up and running so quickly. To just wrap up, I would like to say that a population approach to COVID-19 is really critical to addressing the growing health inequities among socioeconomic and chronically ill populations. And when we think about the context of COVID-19, we also have to factor in many of the rippling effects of the pandemic on the health of individuals, families, and communities. The social and economic ripples of the pandemic are already evident. COVID-19 has shut down businesses, put people out of work. It's contributing to growing food insecurity and maintaining housing and shelter. With schools shut down, many children and college students are not getting the food and lunches that they depend on for daily sustenance. So it's very important that we think about this pandemic from many angles and include the behavioral, cultural, and social and environmental factors that we know affect outcomes. And one of the things I'll just say is that we see is that more and more people in the United States are living on the edge of poverty. And this has actually been a growing trend where we see a widening of income inequalities between the wealthy and the poor. And research has actually shown that the wider the income inequalities are in a country, the wider the differences are in health outcomes and life expectancy. And I think COVID-19 is really pulling back the curtain and showing us what many of us have known for a long time, and that this pandemic, like a lot of health problems, disproportionately impacts vulnerable populations here in the US and around the globe. And these include, especially individuals in communities living in poverty or who are homeless, hourly workers, the elderly, and children with special health care needs. So that concludes our webinar for this week. And I really want to thank our panelists, along with Sherry, Jeannie, Peggy, and Jason for a really wonderful hour. And I want to thank all of the participants for joining us. And I hope you'll come back next week for another lively discussion about COVID-19. Thank you so much for joining.